Eastern, so we're going to go ahead and get started. Welcome to our call today to discuss the Ombudsman program and COVID-19. Before I introduce our speakers, I want to say thank you for all that you and your program representatives have already done in response to this pandemic. As State Ombudsman, you have been very quick, yet very thoughtful in providing guidance to your representatives and information to residents and families and the public. This situation is impacting everyone immensely, and there are still many unknowns. So thank you for advocating for those that are most vulnerable and for sharing your guidance, policies, and experiences with us, and also for giving us a little bit of patience because it will take a bit sometimes for us to figure things out in order to respond to your questions. Since the situation and guidance continues to evolve, I'm very glad that we can have this call today and hear directly from the Administration for Community Living. Today you'll hear from Edwin Walker, Deputy Assistant Secretary for Aging and Director of the Office of Long-Term Care Ombudsman Programs, Hillary Dallin, Director, Office of Elder Justice and Adult Protective Services, and Louise Ryan, Ombudsman Program Specialist. All lines are currently muted, and you're encouraged to submit your questions using the chat box. Please, when you joined, you may have heard that you can hit star to unmute. Please refrain from doing that, just so we can control the background noise. If you do have a question that you need to ask verbally instead of in the chat box, you can hit more as an option that's next to your name or in the chat box and select the thumbs up icon, and then I'll unmute your line, your individual line, so you can ask your question. Questions will be addressed after a few slides, and then after the Q&A, I'll review some resources and talk about our next steps at the Resource Center. The slides, materials, and recording from today will be available on our website shortly after the call, and we'll send an email once they're posted so you'll know. So with that, if you can go to the next slide, Katie, and I see some messages. Edwin, were you able to get unmuted?
I hope so. Can you hear me?
Yay. I can. Welcome.
Great.
Thank you. Go ahead. Thanks.
Oh, hello, everyone. And I want to really thank the Resource Center for hosting this call, and we really appreciate it. We understand how incredibly busy everyone is and how difficult a time this is. We just really wanted to quickly give you an overview about how involved we have been. You know, the federal government really has been working closely with state, local, tribal, and all of our partners, as well as public health partners, to prepare for and respond to this public health emergency and now pandemic. Within HHS, we have multiple work groups that are tackling different elements of our response, and all have articulated a clear commitment to ensuring accessibility and inclusion of older individuals and people with disabilities, and are really making a good faith effort to deliver on that commitment. One work group is specifically focused on meeting the unique needs of people at risk of serious illness and from COVID-19, and it includes older adults and people with disabilities who have chronic medical conditions. At ACL, we are involved in every level of the HHS response. We're participating in work groups that are serving as the department's advisor on issues affecting older adults and people with disabilities. Our regional administrators are plugged into state response efforts and are ensuring that local needs are known at the federal level. We are working with our colleagues across the department, particularly in CMS, CDC, and the Office of the Assistant Secretary for Preparedness and Response. And we're doing that to ensure that the needs of our populations are addressed throughout this COVID-19 response. It includes things like working to classify direct service providers and caregivers of the aging and disability networks, as well as long-term care ombudsman, as part of what they initially considered the healthcare workforce for purposes of planning for federal support to states and for individuals who need personal protective equipment, such as face masks and the like. We are ensuring that all COVID-19 response actions and facilities including but not limited to medical treatment and facilities, are accessible for people with disabilities. We are providing critical information in multiple formats and in plain language. And we're recognizing that a public health emergency may necessitate infringement of some individual rights, but also ensuring that people with disabilities are not disproportionately affected. ACL is also sharing information with the aging and disability networks, as well as people with disabilities and older adults, about program-specific guidance. You saw the guidance that came out last week. We are publishing more today, which Louise will walk through a little bit, Louise and Hillary. And we're distributing it also through our regional administrators, through our technical assistance centers, and putting it up on acl.gov. In fact, when you look at the acl.gov COVID-19 section, it's in the upper left-hand corner of our homepage, and it's really intended to make it easier for our networks and people to find information that they need most. In most cases, we're linking to the most definitive sources of information, whether that's CDC or CMS, and we're putting it right there so that as they update it, it is updated and you're always getting the most up-to-the-minute information available. When there are significant updates, we are also sending out via our ACL updates email service. And if you haven't signed up for that on any page on our website, you can sign up. It's at the lower right-hand corner of our website. And basically, we wanted to say that we really need your help to continue to try to respond in a manner that's most helpful. You, our grantees, and our stakeholders are truly the eyes and ears on the ground. We know that you know the issues that people have experienced and what you are going through and your volunteers are going through, and we want to continue to share information with you, respond to you, and give you the best that we possibly can. Please know that the volume of information that's being generated by HHS is truly enormous. Every effort is being made to make information as accessible for you, direct stakeholders, for consumers, but you know, this is an area we need to continue to work on and improve. We're working to ensure that electronic materials are fully compliant with 508 requirements, that the department is making a concerted effort to use plain language, that they are working to translate information into multiple languages, including American Sign Language. And please let us know if you are finding problems with any of the particular products that you see on our website or other HHS websites, because if they're not meeting the needs, we need to know that in order to make the appropriate adjustments. The resources that are being distributed and disseminated by our technical assistance centers and our grantees really are crucial to informing the people we serve and the people who are volunteering at the state and local levels. So continue to share with us what needs to take place, what more we can do. We don't want to duplicate efforts. We want to be effective and efficient. And we hope that we will get through this in partnership with you and in a way that is informative for you. So with that, I'm going to pause and then turn it on to Louise and Hillary. Or I guess I turn it back to Amity.
Hi, Edwin. This is Louise. Sorry.
Go ahead, Louise.
Oh, I was just going to say we could just continue on. So I'll just continue on if that's all right. I think, Edwin, you really summarized a lot of what ACL is doing, and you know, we're going to talk a little bit more about you know, of course, the Ombudsman perspective. And so, Edwin, I don't know if you wanted to continue on for a couple more slides, or if Hillary, you wanted to say a couple words before we get into more of the formal part of our presentation.
Edwin, are you there? Are you with us?
I had to unmute myself again. But
Yeah,
go right
yeah,
ahead.
okay.
It's fine.
All right.
Jump right on in.
Okay. I think I was supposed to say this a little later, but it bears repeating, so I'll just say it again. You know, we are living through that famous curse that we all tell ourselves so often, may you live in interesting times. These are probably the most interestingest times any of us, I better be, will ever live through. And what I said to Louise over the weekend was, unless there's somebody around who's old enough to not only have been there, but to remember what it felt like in 1918 when the so-called Spanish flu pandemic hit America, then you don't know, and none of us know. This is an entirely unique situation, just like it's a unique form of coronavirus. It's a unique experience for all of us. And it really is going to require a huge effort for all of us, and especially all of us on this call, because we are just, you know, to the depths of our being, we are advocates. We want to be there. We want to do what we have passion for. And we've got to balance that now against the imperative, especially over the next few weeks, to, as Dr. Anthony Fauci, probably certainly the world's most famous virologist, and probably the most, he's been through a lot of viral epidemics and pandemics, what he's describing as flattening the curve, which is to say that because we all need to take such extraordinary steps to not expose ourselves and others to the risk of this virus, because that's the way that the people we most care about, who are the ones probably at highest risk of anyone in the country, and that is residents of congregate long-term care facilities, they're the ones at the most highest risk. To mitigate that risk, we all need to do what we can to make sure that the incidence of infection does not spike early, because that could overwhelm our healthcare system. And I'm just channeling Dr. Fauci here. We need to practice not only the best of hygiene, but also the best in social distancing, which again is not it's not what we do. It's not the nature of what we do. And so it's very hard. But that's what we've got to do at the same time that we use every inch of our creativity to maintain our operations and to have you doing what you do in other ways than, for the most part, than the face-to-face. And Louise is going to get into all of the details, but I think we just wanted to impress upon everyone, including ourselves, because we've been talking this to ourselves a lot, how important it is to balance the public health of the world's population, and especially the folks we most care about, who are residents of long-term care facilities of all kinds. We need to balance that public health interest with the advocacy imperative that is so important to all of us, and walk through this with very mindful of both sides of that balancing, and get to the other side and get these folks we care about to the other side as well. So just keep that in mind, and I think you all know this. Louise is available to you. Edwin is available. I'm available. We are here for you, and we want you to not be hesitant in any way about getting in touch with us or about our wonderful colleagues at the Newark. We will be supporting you as we have been and get you through this as well. So I think we should turn this back to Louise now to walk us through some specifics, so that we can know what's available. Thank you, Louise.
Yes. Thank you, Hillary. So just to follow up on what Hillary said, and thinking about your role as, within the Ombudsman program, as we all know, you're not first responders. And in a sense, this is a pandemic. It's also a national disaster, and we're used to more of the weather type disasters. But this is a national disaster. And so again, you're not first responders, and we know you're so concerned about the residents, as we all are, and just the challenges that they're facing now. It's very difficult. But wanted to kind of review, your role in supporting residents within this pandemic. It's going to call on your programs to be very creative and to really look at ways to promote the program in a variety of ways that maybe you may not be as comfortable with. And also, you're going to have to really work with the facility staff more closely as best as you can. And I know they're under stress, and I know how challenging some individual facility staff or administrators can be, but this is, we're really going to have to rely on them to get to residents in various ways. And we don't want to repeat what is in the information that we sent out last week, but I really do encourage you to really read carefully over both the emergency preparedness and response, the model policies and procedures for state long-term care ombudsman programs. Look at that for ideas if you haven't implemented that policy and procedure. And then look over the guidance or the information that was sent last week as well, specific to ombudsman programs. And there's some tips in there about, how to reach residents short of visiting, and, other things you need to consider in terms of continuity of operations. So, please review those documents. Next slide, please. And I think, as Hillary, really, I think described it well, personal safety here is paramount, and it's very challenging when we want to be the advocate out there in the facility to have to recalibrate. But I happen to be in Seattle, and I've seen this, very up close and personal with a facility just across the lake from where I live, and a facility I visited many times over the years in the past, and to see, I think they're up to 25 or 26 residents who have passed away, about 25% of the residents in that facility. You can see how dangerous this coronavirus is. So, for our own protection, and, again, right now being in Washington, the state has just basically told restaurants and gyms and everybody else to close, other than grocery stores and gas stations. So, it's a very unusual times. And, again, that whole notion of the way we can protect ourselves is to kind of go into some, self-isolation. Next slide. So wanted to get to the CMS revised guidance, because there's been a lot of questions about that. And I think many of you were maybe it was a little uncertain what was meant in the CMS revised guidance with, in particular with the Ombudsman program. And so this is copied from the guidance. I didn't copy what was in A and B because I wanted to jump down to C. And this is about resident visitation. And so what you see in the red is what they added. So they did guidance on March, it was Monday, March 9th or 10th, somewhere in there. They sent out guidance on Monday, and this guidance on Friday, March 13th. What you see in red is what was added on March 13th. So in essence, the residents, they are affirming residents have right to access the Ombudsman program, and the access is to be restricted as described above. And then there's this, however, facilities may review this on a case-by-case basis. So it was a little tricky to kind of interpret. So if we could go to the next slide. I got confirmation from CMS that this is their intention, that basically facilities should restrict visitation of all visitors except in circumstances of compassionate care, such as end of life, healthcare workers, and surveyors. So those are kind of the three groups that have access. The long-term care ombudsman program is not an entity that has an exception to the ban on visits. However, there might be some limited reason related to compassionate care, which seems a little odd for the ombudsman program, or some complaint issue that the program receives that might cause reason for a visit. However, another however, or regardless, an ombudsman could show up at the door and that administrator could say, you're not coming in, and that would be that. They can still restrict access. So, and then of course you have anything going on within your state. So the governor's declaration or the local county health district declaration could be even more strict, and CMS will support that. So, you know, there's, in practical terms, it's going to be very rare right now that you are visiting a long-term care, a nursing home. So it's, you know, it's tough, but again, based on what we've seen, this is the direction that CMS has gone. Next slide. And Hillary spoke to this earlier, so we won't get into the nitty-gritty, but you can see the data coming from China and how harmful this is to older adults. So, and the CFR means fatality rate. So, and among people with critical health issues, it was 49%. So it's, again, you know, we can't underestimate the seriousness of this virus. Next slide. And again, I'm not going to repeat what Hillary said, but, you know, just to recognize that this is just, it does feel odd when most people around you feel fine, that all these dramatic measures are happening, but it's really the only option we have now. Next slide. So in terms of what you can do now, again, I can't stress enough to look over the model policies and procedures, but really to start anticipating, if you're not already teleworking, that's a strong possibility. Work with your agency to ensure that you have access to your agency network if that's not already established. Communicate with host agencies if you have local ombudsman entities. And also, you know, review the continuity of operations information in Section 400 of the model policies and procedures. And then think about how you're going to manage. Teleworking can get isolating. It's also can be hard to kind of like leave work, you know, if you are in your home and it's sort of your computer's always there, your phone's always there. So think about your own self-care, and for your staff, their own self-care. You know, try to establish routines of, you know, not working on the couch, but having a workspace. And, you know, if this is all new to you, to try to, you know, kind of get into a rhythm of working and then taking your time off, because, you know, this could be in it for the long haul. And so we've got to figure out those ways to make this a temporary normal. Next slide. Some other things, just thinking about if you've not teleworked before, you know, and, you know, I know sometimes as phone numbers and phone systems have changed, or I've physically relocated and all that, sometimes I'm not up to date on, well, how do I get to my voicemail, you know, those kinds of things. So make sure that you and all of the staff can access voicemail remotely. You know, update your websites as you need to make sure you've got the most recent contact information. You know, if you've had turnover of programs or staff in local entities, make sure that's all up to date. Please make sure to look at what's on the Ombudsman Resource Center map and make sure that your program information is accurate. And if it's not, send that into the Resource Center right away. A few other things I'm kind of learning as I go, being remote, is to know that sometimes internet access might be spotty because so many people are teleworking. Sometimes your own agency network might be a little spotty. You might get kicked out of your network and have to get back in. So it might be a good idea if you're working on documents to make sure you back them up where you can get to them on your computer and you're not relying always on your agency network. And also have your hard copies of, important phone numbers, just things that you can have at your fingertips. Keep that handy. Next slide. So a little bit more, I think I'm seeing so many of you, and thank you for sharing, you're revising your policies and procedures. It sounds like you may have to be prepared to revise them again. Now is the time to really network with your partners out there. It's just a fast-moving crisis. And so, for example, one state shared that they're meeting daily with their inspector general and the provider associations and an emergency response coordinator. And, they're just checking in every day. So, see if you're not involved in, say, meetings, check-ins with state survey or other public health, et cetera, see if you can get invited. Check in with the provider associations, working closely with them and getting them to message to their members that they need to, help the ombudsman to reach residents. It's going to be really important to have a close relationship with them during this time. And just so you know, we are also working at the national level with the 3 provider associations. So Leading Age, American Healthcare Association, and Argentum, to make sure they have some just simple handouts to give to people about the Ombudsman program. And so we're working on getting that out now. And also we are going to talk about some of the concerns that you've been sending me to talk about, families who have a relative at end of life and they're being barred access, or just some of those issues you've shared. We're going to alert them to that as well. So we're trying to kind of do a parallel. Again, Edwin described that quite well. And also, I just wanted to share a little bit more about our work with the provider associations. Next slide.
Louise, as Amity is turning to the next slide, I just wanted to also observe that we are also, of course, working very closely with APS and with Legal Aid.
Thank you.
These are obviously partners of or closely related networks to yours all over the country. So we're going to be providing them with similar guidance similar advice, tips,
information,
a document today or tomorrow, and also arranging, similar to this webinars for them as well. So just trying to, tamper everyone's totally understandable worry and anxiety with information and with at least warm voices over the phone, connecting folks to each other. So if any of you have any questions about your work during this terrible time with APS and or with Legal Aid, please let Louise know, and know that Louise and Edwin and I are talking just about daily. So we will make sure to address anything, send out the great ideas, and also address any issues that may come up.
Thank you, Hillary. Yeah, great interjection there. And again, just, the ways in which we're trying to make sure we're all on the same page and, kind of cross-coordinating the messages we're giving to the networks. Another thing I wanted to just mention in terms of your outreach is I think it's really important that you try to communicate with the media. If you have communications staff in your agency, work with them, get some help to, write a real simple press release just to say, hey, we're here, call us, email us, file a complaint online, et cetera, and say we are limited in our visits right now, but we're doing what we can. Be that reassuring voice. Communicate with elected officials to let them know that the program is a resource. If they might need that reminder in this time of crisis that, you are still there to receive complaints or questions from their constituents. Mail information to the facility, mail your brochures and ask them to distribute it or post it. I think sometimes the Ombudsman program is the best kept secret, and this is a time where you're kind of more out there advertising is really important. Of course, there's social media as well, but sometimes social media doesn't hit our population as closely, The other thing is think about public service announcements on the radio, those kinds of things. Next slide. So just a few tips on communication with residents and families. Again, your method might be different, but you're still attempting to address the issues related to the health, safety, welfare, and rights of residents. A few extra considerations. Your email and phone traffic may increase. Keep in mind that your communications are Ombudsman program records and are confidential. So in particular, think about that with your emails or if you are texting. That is part of your program record. So you want to make sure it's protected and that it's not, think of those things like the group emails. Sometimes you really shouldn't be doing a group email when it's like a resident issue. So be careful about those communications. Ensure that you are continuing to document in your software systems cases and complaints. So I'm getting from State Ombudsman what I would call complaints about access. Those need to be documented as complaints. If you are going to take action and try to do something about it, you've got a case, you've got a complaint, and so document that. Really it's going to be important to have that data as we look back and see what happened. So please, I know a lot of state ombudsmen, myself, I was guilty sometimes, would work on an issue and then, oops, I may have forgotten to document it and I'd go back and do it, but it's easy to forget. Another thing I would say in terms of email communications, I mean, we all, have our bloopers, and so you want to be really careful. Sometimes I'd say less is more. Sometimes some things are easier to discuss in a telephone conversation than to try to do a lot of back and forth. So again, especially if you're dealing with families who are upset, sometimes the voice over the phone can be a lot more reassuring. So, think about those things as you are kind of entering this new world. Again, with social media and Facebook posts, you obviously you want to be careful about what you post there. So just think twice before you press send, and just use that kind of caution. And if this were me, would I want this in some way to get out? Kind of over your, with that kind of hat on. And again, I just find sometimes email can get very convoluted. So sometimes just picking up the phone can be more helpful. Next slide. Communication with providers. Again, your goal is to address resident complaints and to ensure that the residents' health, safety, welfare, and rights are respected within the context of COVID-19. And we know right now that lots of rights are unfortunately kind of been pushed out the window. And residents are being isolated, and visits have been prohibited. So it's incredibly difficult. And so what are some ways you can, talk to and work with the facility to, get that resident contact information? Can you set up phone trees? If you've got volunteers, this is a great time. The volunteers can't visit, but can they be given a list of residents to contact at their facilities that they visit, so that they are, touching base, just being a friendly voice over the phone to check in and see if everything's okay. Of course, we know in particular in nursing homes, a lot of residents aren't able to use the phone because of cognitive challenges in particular. So again, then you're trying to contact the resident representative. And I would say anything I'm saying, and I use the word nursing home, you can expand that to your other settings. This, clearly the limits on visiting, although we have the federal oversight of CMS for nursing homes, I know in many states they are also limiting visits in other settings, such as assisted living or similar, residential care settings. So, this applies, I think, to all settings at this point. Next slide. This is again where it's going to be, you're going to have to rely even more on the facility to resolve problems. And in particular, if you need to access records, you're going to really have to depend on the facility staff. So for instance, and when you think of the Ombudsman program rule, it says you need to ascertain if a person is actually the guardian or power of attorney. Well, it's going to be hard if you can't see the paperwork. So, you may have to trust, what the provider says. You're going to have to trust what a family member says when they say I'm their power of attorney, and then later figure out if you can, more factually verify that. Again, with phone communications, facility staff may need to help residents to use the phone or other technology. So privacy could be a challenge. Of course, care conferences can always be done on the phone or maybe through video conference. So be thinking of those methods. And I would say you're going to have to be patient with facility staff. They're clearly, I'm sure, under great stress right now. The other thing is, if you are requesting feedback or whether it's a follow-up call or they're supposed to fax you something, see if you can get from them, when can I expect this? Is it tomorrow? Is it in 2 days? Try and pin them down as best you can. And, but be understanding and all of that. I mean, this is where we've really got to try to, just be as patient and calm as we can with the providers. Next slide. So, again, we've said it many times, this is unprecedented, and we are all learning as we go. We'll continue to represent the Ombudsman program and the needs of residents, both within HHS and other federal agencies. We all need to try to stay calm and be patient. And, as Edwin said earlier, and I will turn it back over to Edwin to, will keep us informed of both your challenges and successes. And I think with that, I did want to turn it over to Edwin, and then we're going to go to question and answer.
Okay, well, thank you. Thank you so very much. I just think that, I want to thank Louise and I thank Hillary because we've just been so grateful for everyone's dedication and time with regard to addressing this issue and trying to respond as rapidly as we can. I think the most critical thing is for us to hear from folks on the line. So I really just want to turn to the Resource Center and, we've talked about how unprecedented the times are 1,000 times. We just want to get to hear from you and try to respond to any questions that you might have. So, Amity, how do you open the line?
Thanks, Edwin. Hi, everyone. So if you would go ahead and submit your comments in the chat feature, or like I said, if you click on the little button that says More, and then hit the thumbs up sign or clap sign to get my attention, I can unmute your individual line. We just don't want to unmute everyone's line at the same time. So.
And one thing, we do have a kind of pre-set list of frequently asked questions that we will share with you. So after your general questions, we'll just review the frequently asked questions if they haven't yet been reviewed.
Thanks, Louise. And just as a reminder, we'll share the webinar slides, recording, and those FAQs that Louise just mentioned after the call and post everything on the website. So please go ahead and submit your questions or indicate that you want me to unmute your line, please. At the time, I'm not seeing any questions. There we go. So how are facilities going to train family members if they can't come in and learn how to do family members? If they can't come in to learn how to do transfers, drop insulin, things that cannot be done on the phone, will CMS make this an exception like end-of-life visits?
So,
for discharges. Thanks, Devan. That's why
okay.
I thought you were going there, but I wasn't sure.
Okay.
Thank you.
I think that's a question we have to put to CMS. I don't want to try to answer something like that. Again, there's things like home health. So maybe that's arranged at the home with a home health nurse who's there that day. But we will grab that question, and Amity, is there a way to save these questions?
Oh yeah, we're going to save the entire list, and that's what I was going to say too. I bet that's going to be coordinated with home health would be my guess. But we will write that down and circle back. Thank you.
Yeah, we'll get
so
to
another
CMS
question. Thanks, Louise. What guidance or insight can ACL provide about what compassionate care situations means? It's clearly a reference in part to end of life, but appears to mean potentially more than that. If you know, why was that term selected?
I don't know. Again, that I'd have to ask CMS. I think they were just trying to get an example out and put it very narrow. But, again, we will circle back to CMS on that. I think that the bottom line message I'm getting in my communications is they really don't want visitors because of the danger of this coronavirus. So it's very, very narrow. And I wonder because, for example, my neighbor, they're Chinese, their mom lived with them for many, many years. She's now in a local nursing home, and she won't eat unless her son comes and feeds her. So I've been meaning to go find out, is he still going to feed her? Because she really will not eat if staff try to feed her. So I'm thinking he probably is, but I don't know for sure. So, yeah.
Thank you. Another question, does CMS anticipate a temporary halt to involuntary discharges?
I think we'll have to ask CMS. I'm not sure if they can issue something that blanket of a statement. to nursing homes. So, you know, these are great questions to see what we can get from CMS. Yeah.
I can share that, and maybe this will be something that we can talk about in more conversations individually with states, but there is one state ombudsman that is certainly advocating for that at her state level. So, at least for non-payment. So,
well, and by
question?
extension,
oh, sorry.
For instance, around non-payment, like in Seattle, the mayor has put a temporary halt on evictions for non-payment. So by extension, states or, you know, could look at that for certain, you know, like for non-payment. Yeah.
Yep. Thank you. What guidance do we have for residents who transfer to a hospital and then want to return to their home?
I know this is
Oh, sorry. I was just going to clarify, return to their home as in their personal home or return to their nursing home? And if you could clarify that, that'd be great. Nursing home. Okay. Thank you.
So I don't think the guidance has changed, and this is a something that we've alerted the provider associations to, that we're hearing from you all that this is becoming a problem. But, you know, assuming there's no, you know, reason, it seems like you should advocate for their return just as you would in any other circumstances. So, again, we can add that to our CMS list, but I don't think anything has changed.
Thank you. So do you have any tips or guidance for promoting confidentiality while at the same time relying on the facility for at least some resident communications?
I think we're going to have to put our heads together on that, and as you start to practice, what are you learning? You know, I mean, some, you know, things might be if a resident maybe can't hold a phone, but they can be on speakerphone, and the staff dials the number, puts it on speaker, and leaves the room. You know, things like that. I think it's just going to be experimental. So we'll, you know, again, these are great questions, and there might be some advice from our peers who work more closely with people with disabilities on that. So see what else we can find out. And I think just through your practice, you're going to learn more. I don't know, Amity, if you have other thoughts on that.
I don't at the moment, but I think when we talk about next steps, that's a good example of kind of best practices that we want to start collecting and sharing with you all. So we are documenting things like that.
It also strikes me, I'm sorry, Amity, I didn't mean to interrupt you.
That's all right.
I'm thinking that when Louise and Edwin and I speak to the industry folks, that would be a good topic of conversation for them. What can they do to help to preserve the confidentiality of remote ombudsman resident communications? None of it's perfect, but, you know, as Louise said, we are going to have to rely more than usual on facility staff since they're the only ones inside with the residents.
Sure. And we do have more questions coming in, which I am getting to them. And again, we will copy these and make sure to keep them and keep working on them and getting back to you on the ones that we couldn't answer today. But I did ask Louise if she could stay on for a few extra minutes just in case we're running close on time, and she agreed to do that, and I'm happy to do that as well. So if we don't get to all the questions, we can keep going for a few minutes longer at least. So a question that may be something that may need to be addressed eventually individually with the state, but I wanted to share it broadly in case others start encountering it. She said she has 2 regionals who are the only social workers left in their AAA that are not on quarantine. So they've pulled those 2 people to do care coordination duties. I told the AAA that they could not use Ombudsman funds to pay for this and that the Ombudsman still had duties to fulfill, although they weren't going in person on visits. So guidance, please, on handling that situation.
It seems that you would have in your contract or grant to that agency what they can and can't do. So we may need to talk further after this call. We can do some problem solving there. And yeah, any money that was allocated from Ombudsman program funds should not be used, you know, for this other work. Yeah, that's, so maybe we can follow up. Edwin, do you have more to add there?
It's not directly on that, but I'm being pulled to go review some legislation. I just wanted to say, from an advocacy standpoint, we are aware that components from the Aging Services Network has gone to the Hill in an attempt to secure additional resources, and that they're probably, well, certainly you all have heard of a second supplemental. The first one was a week or so ago for $8.3 billion. It did not include us. The second one includes meals and has passed the House, is sitting before the Senate, or it may have passed the Senate this afternoon. The President in his press conference on Friday indicated he would be signing that. It would be for $250 million in meals. And the third one that we have heard about would include additional resources for the Ombudsman program. So as a network, you need to check with other national aging organizations and be supportive of that third supplemental. But I've got to run, so thank you all so much.
Thank you, Edwin.
Thank you, Edwin. So one comment, not a question, but just something to take note of on the involuntary discharges was a suggestion that if CMS would at least say no discharges to homelessness shelters or homelessness in general.
And I think when the advocates meet with CMS, that would be important, you know, for the advocates. There's a group that meets with CMS. Melanie represents state ombudsman. And so definitely, you know, as you in your association does your advocacy work, NASOP may want to think about their own press release about some of these broader issues or, you know, things like that. So,
yeah, and this is Hillary. I would just add, think about where beyond homeless shelters, you know, think about the experiences you've had, you know, not to the street corner, not to the front porch of the grandson who never agreed to take grandma in, or a hotel with 2 nights paid for and then on the street. There's kind of think about what in that advocacy group conversation with CMS, you know, how to convey it. The folks from CMS have certainly heard from you all before on the discharge issues, so it's not like this will be a surprise to them, but just to remind them that in this situation, maybe something a little more is needed.
Great, thank you. And a comment in the chat feed from Patty just to everyone said that her state survey agency has been great regarding involuntary discharges and speaking with provider associations that residents must come back into the facility after hospital or home visits. So good to hear. Let's see. We've been asking for census lists, resident and resident representative phone numbers, as well as POA and guardianship paperwork to help with communication and vet decision making. It looks like that wasn't a question. Sorry about that. I'm just reading as we go. Thanks for sharing that. Another example for privacy would be to ask the staff support to leave the room as Louise suggested, and would ask the resident who needs a staff person to support throughout the call which staff they want to do that.
Yeah.
Great. Another good suggestion. Thank you. Question, is there any word on Medicaid extending home days so residents could potentially go home during this crisis and it not affect their eligibility?
I haven't heard anything about that, but again, we can do some research. With the declaration of the Stafford Act, which is the official disaster declaration that does loosen up some requirements. So we can find out if there's any thought to that. Thinking of like when a natural disaster happens and the nursing home closes and, people go like elsewhere, it's kind of so yeah, we'll do more research there.
Thanks. Question, we have grave concerns about assisted living that use adult daycare settings as our adult daycare facilities are closing after today. Any suggestions of advocacy when we can't go into the facility and if the survey agency won't go into and investigate either? Do we call the police, APS?
So my assumption is they use adult day health care to provide extra supports like nursing or rehab, whatever. So the question becomes, what is the facility going to do to fill the void? And so that's what I would be talking to either the individual providers or the provider association about that. So I don't know if I'm missing something there, but it's really about I see it as the service needs of the residents, and so what is the facility going to do? And that's the question you have to ask them. And again, if you can get a list of the residents who are going to adult daycare and follow up with them about their needs and to find out if their needs are being met. Yeah. Are you there, Amity?
Sounds very quiet
yes.
all of a sudden.
Sorry, I apparently muted myself. I was adding a comment to your response to that. The state ombudsman said these ALFs don't have staff during the day. They actually have other jobs, which I was saying, wow, that's a whole nother issue.
Yeah, and then you need to be talking to survey agency as well,
because they're licensed to provide care. So.
Yeah, so yeah, there's something very amiss there. So yeah, and maybe this is more around serving people with developmental disabilities, maybe, where that might be a more common approach. So I think, look within your state, this might be good to also talk to your state's protection and advocacy. You might need to be in touch with legal services or your legal counsel in particular to look at options.
Thanks. So going back a few comments or questions about the two individuals at the AAA, kind of a follow-up question for consideration is it not allowable in the federal rules for an ombudsman to be utilized for non-ombudsman services on a time-limited basis, considering we may see more and more people in quarantine and whatnot?
Well, that in the rule is specific to the state ombudsman being full-time. So the example given was about local ombudsman. And so the local representatives, that is more around what's in their contract or grant around what they're supposed to do for the ombudsman program. And again, the sources of funds used. So you can't use Title VII, Chapter 2 ombudsman money to do case management. That's just not allowed. So again, looking at those sources of funds. So yeah, so it's a different context that, yeah.
Thank you. I believe those are all the questions because one question was actually answered within the chat, so thank you all. And the other question was really for Newark, which I'll address in a couple minutes on the slides, was asking what helpful examples or resources for state ombudsman to share with Newark. So what would be helpful for you all to share? So I'll go through that in a moment. Louise, did you want to address the FAQs at all?
Yeah, so we've got some FAQs based on questions that were sent in earlier And we'll keep building on this, but I hope that we'll get this also posted to the ACL website today or tomorrow. So, and again, the questions are evolving. You know, some of the early questions had more to do with visits, and we kind of know where things are at, but I included them anyways. You know, some of them are, and again, some questions and answers are more basic than others, but I, again, don't want to assume, so I've got some very basic and some more complicated. So question 1, what should a program do when a governor, director limits travel, etc.? Programs need to follow the declaration of the governor and agency leadership. So, you know, very straightforward. There was a question earlier in the week about is the Ombudsman program really considered to be a, quote, visitor when they're also a health oversight entity under the Health Insurance Portability and Accountability Act, also known as HIPAA. So I'm not going to read the full answer, but HIPAA is really about privacy of clinical records and access to those records, not necessarily about access to individuals. So the answer has a reminder about the HIPAA memo that AOA did years ago that is still in effect, and then a couple of bullet points from the HIPAA memo. So the third question was having to do with, in light of state survey agency guidance to prioritize complaints, with whom can we work with if our survey agency is not involved? So I guess I want to say, and maybe I should have changed the question a little bit, your survey agency is still involved, but they are prioritizing complaints. So I think you should just continue to refer any complaint that you would have referred to state survey, continue to refer those. Don't say, oh, well, they've prioritized, so I'm not going to send this whatever complaint, you know. Just business as usual in terms of your referrals. Just know that they might not make it into that priority. So CMS, you know, has this priority of immediate jeopardy, complaints alleging infection control, statutorily required surveys, revisits necessary to resolve current enforcement actions, initial certifications, surveys of facilities, hospitals that have a history of infection control deficiencies at the immediate jeopardy level in the last 3 years. And then there's the other one, history of infection control at lower levels in immediate jeopardy. So that is, I kind of listed that out in the Q&A just so you have it handy. And then the fourth question, I think we probably talked about this already, but we have a question about how do we determine or verify if a resident has a decision maker when we cannot personally visit. And again, you're going to have to rely on facility staff or family for help with that. Again, the Ombudsman program rule directs the program to ascertain or confirm this authority as a decision maker, but it doesn't say how. It doesn't say you have to personally look at it. So, you know, again, it's just have confidence and some trust initially in what the facility or family is telling you. How shall we obtain written consent to access records? So there are times when your program wants to get written consent, and so I think you're going to still follow your policies and procedures. And in these instances, you're likely going to start with oral consent that you document right away, contemporaneously, if I can say it, and then or through other technology, and then, you know, for those more traditional residents who can use traditional communications and can sign a consent form, you can always follow up and mail one, or if staff have time and they're willing to receive a faxed form to give to the resident and fax back. So those are just, you know, again, some of the ways. You may have, you know, your website might even include those that residents or their families can, you know, fill out in some way, in some protected way. I don't know, just throwing that out there off the top of my head. Or you may have a fillable form that you can email to a family member. So, you think of your ways that can be done. And again, these are for the circumstances where you need that written consent. You don't necessarily always need that for every complaint. So if you have always documented certain complaints that you got oral consent, you would just carry on as usual. Likewise, with disclosure of resident records or other information, continue to follow your program's policies and procedures regarding disclosure. Quite often, you're going to just have to start with verbal consent from the resident. Say if you need to look at the resident's records, you can follow up again by mailing or faxing that consent form when you need to get that. So, this is just a start of the FAQs. And, I think we've got a lot of good ones here today that we can build on. Some that are really more for CMS to answer. I will see if CMS can do that. And so stay tuned there. So that's what's in the FAQs for now. And we will, keep building on them. So.
Thank you, Louise. Katie, if you'll go ahead and go to the resource slide, the first resource slide. So I just want to take a very few minutes at the very end of this to remind you of what we already have available and what we'll continue to do. So on the private side, State Ombudsman side only of the website, we have links to the CMS, ACL, CDC guidance, Newark and consumer information, as well as lots of examples from your peers. And again, as this continues to evolve and change, we also need to update our website, so that's on our list to do so ASAP. But we have examples of public outreach, letters, press releases, communication with representatives, providers, program policies, and procedures. So those are the kind of things we'd like you to keep sending to us, as well as all the guidance that Louise just went through about working with the media, working with your state representatives, policies on remote work, best practices regarding confidentiality and reducing isolation. So as you start figuring these things out for your state and maybe some best practices you're seeing by providers, keep sending us that information too, and we will compile it and get it back out to you all so you can continue to learn from your peers. So that's on the private side of the website. Next slide, please. These are links to additional information, including our public side on COVID-19, which again, we are tweaking and revising based on the most recent guidance on restricting visitors. We have a couple issue pages, and the Newark app is also being updated as well. And then Consumer Voice has a page too. Next slide. So our next steps, as I said, we're going to continue to update our information to you all, including our web pages, emails, Newark notes, and so on, and social media. We'll continue to collect and share examples from you. And then I really think this is our immediate next step, is compiling and sharing examples of best practices, because like we all know, we need to help reduce social isolation, ensure communication between residents, families, and the Ombudsman program, and even some best practices for providing entertainment and activities for residents during this time, kind of how to make their quality of life as normal as possible during this really stressful time. So as you hear those examples, please share those with us. And then Louise mentioned a postcard and information sheet that she's sharing with associations. We will also make those available to Ombudsman programs. It's a very just simple postcard, and then there's one that's like a half sheet of paper where you can put your local or state contact information on the back, print those directly off our website, edit them, etc., and circulate them throughout your programs and facilities. So we hope that that will be helpful. And last but not least, we'll send you an email once everything's posted on the website. And like I said, we'll continue to go through these questions that were in the chat feature. Thank you for that, and we'll circle back to you with responses. So that is all I have today, unless, Louise, you wanted to say anything else. Last slide, please, Katie. Just a reminder on how to contact us in the variety of ways.
I just want to thank everybody for, I mean, programs have just been, I can see, just working so hard to, you know, rise to the occasion here. So thank you very much for all of your work and all the work of your representatives, both staff and volunteers. And the Resource Center has been amazing. So thank you all, staff at the Resource Center and Consumer Voice. And Hillary, she's been an amazing support, as is Edwin. So, you know, you've got, with Hillary and Edwin are just, they've got your back, and they're looking out for the Ombudsman program. And as am I, and, you know, we'll be here. So don't hesitate to reach out. Thank you.
Thank you so much, everyone. Have a good day. Bye.